those patients have lost around 10% of their weight loss at 5 years. 10% is not a huge amount of weight, but it is a huge impact on health. And so as we're talking about treating obesity, we're not treating someone so that they look a certain way in the mirror afterwards. We can see 10% body weight loss and have massive, massive improvements in your overall health and your overall health span and longevity. And so it's key for people to realize that it's not like Wegovy on board, everyone's going to conform to this aesthetic ideal. No, that's not what we're excited about. We're excited because people aren't going to be dying from heart attacks and strokes at the same rate after having lost 10% of their body weight.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
Our guest today is Dr. Diana Thiara, the medical director of the UCSF Weight Management Program. She also serves as an assistant clinical professor of medicine at UCSF and the program director of the UCSF Obesity Medicine Fellowship. Dr. Thiara specializes in internal medicine, focusing on obesity and weight management. Her work integrates innovative patient programming, culinary medicine, and virtual curriculums for obesity patients. Her journeys from a small town in Illinois to leading obesity medicine on the West Coast is nothing short of inspiring. Her passion for community and medicine, influenced by her father's role as a town doctor, guided her career path, resulting in extensive contribution to medical education and patient care, including the Robert H. Crede Award for Excellence in Community Service. In this episode, you will hear Dr. Thiara discuss the nuances of obesity management, her perspective on GLP-1 drug, and her innovative approaches to patient care. And here's our conversation. Welcome, Diana. Thanks for joining me today.
Thanks for having me.
It's so nice to have you. I've been thinking about having you on my podcast for a while now. It's so glad to finally have you here. One thing that I always like to ask the question first is about your journey and what takes you to where you are today. Walk us through what are things that went through your mind when you said, this is the path that I want to take?
The journey, I would say, was not really, it was pretty straightforward. I grew up in a really small town in rural Illinois. My dad was the town doctor. And so this idea of community and giving back and being a part of community was always deeply ingrained, both from where I grew up and also from a religious background. My family is Sikh, and community drives so much of how that faith is practiced. And so I always knew I wanted to do something where not only was I part of the community, but I was also giving back. And I went to college. I thought a lot about political science and going into politics, but it was very delayed gratification. So you could work on a project for months or even years, and you'd get these small wins at very, very wide intervals. And I learned early on that I'm someone who needs daily gratification and these excitements and interpersonal relationships very regularly to feel happy and excited about work. And so medicine seemed to be a natural place for me and my both academic interests and also just what brings me joy. So I worked at the National Institutes of Health after college. I did a research fellowship there for a year, working with individuals who have HIV, looking at cardiometabolic disease. And I think the obvious sort of theme throughout my life and also in medical school that I recognized was I just really like people. And I love to hear stories and sort of be that person who's a collector of stories, and that felt like such an honor and also very fun. And primary care is a natural extension of that. And so I knew I wanted to be a primary care doctor by the time I was towards the latter half of my third year of medical school. And so I set up my elective experiences in that realm, and sort of coinciding with that, I went to Vanderbilt for medical school, and we had the chance to create our own elective experiences. And so one of them, I trained for the Nashville Marathon. And I got very interested in this idea of health and being active. And so on my free time, it sort of became a hobby, learning about nutrition and activity in a very in-depth way. And the closest thing clinically that was available was doing an obesity medicine elective. And I did that, and I saw how when you provide comprehensive care for obesity, it requires very, very intimate and intensive interactions with your providers. So we got to know our patients very, very well. It's not just surface level. It's all of the things that impact why we eat and how we eat. It often goes back to our culture and our lives in these very deep ways. And I found so much joy in harnessing someone's story with how we can create interventions to help with their future and health. So that felt like a perfect marriage of my academic interests in science and medicine, but also with my personal interests around nutrition, activity, and well-being. And so I decided I wanted to do internal medicine, and UCSF has an obesity medicine clinic. So I was very fortunate to match on the West Coast in San Francisco and pursued obesity medicine and internal medicine simultaneously throughout residency, and landed in a career about 2 years before the GLPs really took off. And then, Wegovy came on market in 2021, and my professional identity really just changed and grew a lot since that time. Yes, I would say when I started, it was a thing that no one really knew about, and there wasn't too much excitement or interest. But that was a powerful proof point for me that I wanted to do something that not many people wanted to do. So it wasn't just about the hype or the excitement around it. Truly was something I, as an individual, found interesting.
And you probably was very excited that you have additional tool in your toolbox.
Definitely.
And one of the things that you mentioned earlier about you like the story, hearing the story, but also create the story can help you create the intervention that you need. And you said mentioning about getting to know the patient. Nowadays, everybody's saying that primary care don't have time. And how do you make that happen to give the time for you to get to know the patient?
It's very correct that in primary care, there isn't enough time. And I was very fortunate early on to have mentors who encouraged me to pursue obesity medicine outside of primary care. So the majority of my obesity medicine work is practiced in the weight management clinic, which does not run like a primary care clinic. We think about obesity treatment and management of the adjacent metabolic conditions and cardiac and whatever comorbid conditions are associated with obesity. And we follow our patients almost monthly. So we don't have really big panel sizes, and we're not dealing with everything that comes in that a primary care provider needs to help manage for their patients. So our clinic is just structured such that we have way more time and a lot of regular follow-up, as well as a robust interprofessional team of dietitians, behavioralists, and MDs, as well as nurse practitioners. So it's just a much higher touch point type of practice.
Do you see that there is more of that kind of center around the country, or how unique is that, the one that we have here at UCSF?
Most major academic centers throughout the country have these comprehensive weight management programs. They really came up mostly on the East Coast, so a very high density of amazing practices in New York, Boston area. Vanderbilt has a great program, and they sort of have started to come out more prevalent across the West Coast as well, but I think it's been a little bit slower of an uptick on the West Coast. So I started the very first obesity medicine fellowship on the entire West Coast of the United States just this year. So there's definitely a little bit more of a lag. And part of it probably is because obesity rates here are not as high. But in the last 5 to 10 years, obesity rates have gone up tremendously nationally, and the West Coast is not spared in that.
And I remember you mentioned in one of your talk about the ratio between the number of doctors who have specialty in obesity management is a lot fewer than what the country needs. And I was talking earlier about with Dr. Sanjeev Arora, who's bringing the founder of Project Echo. How familiar are you with the Project Echo? Is this something that we at UCSF do to spread about the knowledge that you mentioned that oftentimes stay in the university center, to spread it to a lot more different area within the Bay Area outside San Francisco?
The trouble in the obesity medicine space is that the lifestyle change component is still really, it's super, super important, even with the advent of these highly effective anti-obesity medications. And it takes time to do those interventions. So even if we're able to develop platforms that can be delivered to the masses, you need to be able to have the right practitioners delivering that. And oftentimes it can be an MD that's a little bit more low touch and having higher touch health coaches and other providers. But insurance companies don't always reimburse non-doctors for some of this work. For example, if we had health coaches to disseminate a lot of the work and curricula around intensive lifestyle intervention, and an MD was seeing a patient every 3 to 6 months, or even just for short bursts to check in about medication side effects, that would ultimately be a better utilization of time and be cheaper. But insurance companies don't oftentimes reimburse for things like health coaches. And most companies, unless they're large corporations, are not able to finance that type of model either. And so we need to, if we were able to start from scratch, which we talked about at the Rosenman Institute a little bit, it would be great to restructure the way we think about cost and think about cost over lifetime rather than cost over the shorter period of time, because our sort of myopic view of cost savings really limits how much we're able to do on the prevention or the early stages of disease treatment that can lead to regression. It doesn't pair up well always in the long term.
Yeah, I feel like there should be a new revolution try to measure long-term metric, and I don't know how to start that, but I feel like more people talk about it. Hopefully there's a lot more uptick in that. And walk us through a little bit, how does a patient get to you?
A patient gets to my practice if they are a patient at UCSF and have obesity or overweight BMI with a comorbidity associated with obesity. We used to be able to really take anyone who wanted to come see us, but now our wait list is very long. It's almost 6 months. And so we've had to put some guardrails and really focus on the patient population that's within UCSF Health. But I think even broader, in the longer term, we probably will need to think more creatively about who should be coming to us and who can be managed by their primary care provider with us behind the scenes. So we're able to offer advice and counsel to primary care providers within the UCSF Health ecosystem, and perhaps the way our endocrinology colleagues and our cardiology colleagues have been able to pass off some things to the primary care provider and some of the more nuanced, advanced, complicated cases to us. We may need to strike a better balance in order to care for patients more equitably and effectively in the long run.
And So what you're saying more equitably, are you saying that the cardiologists, do they have some set of screening process to make sure that can be distributed equitably for the patient to get the necessary treatment?
I think it's more of a culture at UCSF. The average primary care provider within the UCSF health system has a good handle on the basic treatments for things like hypertension, high cholesterol, and patients can be graduated back to primary care if some of their other advanced conditions are well controlled. And I think part of the pressure point in obesity management and these new medications is that there's so many individuals who have obesity that it would overwhelm a specialty, but also these medications were advertised to consumers before the studies were even published. So even before a doctor could read about something in the New England Journal of Medicine or whatever, JAMA, the drug companies push out top-line results, and then those top-line results get picked up by major media companies, and then it goes out to the average person. So we see these results that say, this drug, you'll have X percentage of weight loss, but the paper hasn't even been published yet. And so this makes it such that providers, especially primary care providers, have to take up utilization very, very quickly. And it's not as much of a approach where it goes from specialist out to primary care after we have a system created. So it's been challenging in that way, I think, for the average primary care provider, because they don't have the time to learn how to learn about the drugs and how to use it, because it was given to the information was given to the consumer so rapidly.
It's almost in that way, but what they're doing now, they have to catch up because maybe the data is not available quite yet. But are they doing what they're doing now when you see patients who are requesting this particular medication? Do they then send it your way, or this is something that they would be able to prescribe on their own?
At this stage, most providers are able to prescribe the GLPs as well as the newer GLP-GIP class of medication. But there is a difference between success and adherence when someone is able to have high touch points with their providers and when they're not. So I think a lot of what we see on social media is this phenotype of either someone who loses incredible amount of weight very quickly, or someone who's just feeling miserable and all of these side effects, and that's just normal. And so a lot of patients, when they ask about the medication and you explore what their understanding is, it's sort of like, well, I know I'm just going to feel bad for the next year or so, but it's worth it. And the truth is, our patients in our clinic tolerate these medications quite well. And if they're feeling sick and they're feeling unwell and their quality of life is worse, that's actually a sign that this is not a good medication for them. And we're able to mitigate a lot of side effects through dietary counseling, timing of medication, slowing down titration and things like that. But the average primary care provider just doesn't necessarily have the bandwidth to do so much intensive treatment. And so maybe that's a use case of someone who should come to us, and maybe someone who is tolerating the medication very well and has a good understanding of nutrition and is regularly active can go along the PCP route where they're managed without monthly visits.
Mm-hmm. So this is becoming more on, it falls on the primary care responsibility to kind of triage, like this is a patient that we can handle, and this is some patient that should go to your center.
That would be the ideal scenario. I don't mean to imply that a primary care provider should ever take on something they don't feel comfortable with. And I think primary care providers do an amazing job learning after they've had a few patients see a subspecialist. And so it may be the case, too, of somebody sending patients and over time becoming more comfortable as they've gotten more notes from their subspecialists or they've learned more on their own. We're obviously happy to see anybody. So if a PCP doesn't feel comfortable with these medications, the best and safe thing is to refer to us and not to have this sense of knowing what to do just because they feel a sense of pressure around it. But our wait time is very long. So I can see how some providers would feel a sense of pressure around doing something if their patient is asking them repeatedly to give them an intervention that they technically and medical legally are able to offer.
So do you think now if you have weight issues or overweight or obesity, nowadays it's like the first line is the medication?
That's an interesting question. If somebody has chronic obesity, so they've had excess weight for years and they've been really engaged and have just had a hard time, and I'm meeting them for the first time, medications would definitely be on the earlier side of an intervention. If somebody has been a stable weight for the majority of their life and had one big stressor or something major happening or maybe something minor happening and they've had rapid weight gain, you definitely want to rule out to make sure there's not another cause. And for everybody, you want to make sure lifestyle change is in place. You want to be eating healthy foods, moving your body. And for some people who haven't had chronic obesity, their body will start to naturally lose large amounts of weight. And so you kind of see how long you're able to sustain that weight before adding on a medication. But for others with chronic obesity, no amount of lifestyle intervention is going to help reduce the weight. And so adding a medication early on would make sense.
It feels like sometimes that, this is great to have. And also now there's so many, like you were saying earlier, that the information that is being pumped to the consumers is much faster than the research, the study, the data. And one thing you hear all the time is like, oh, now it can treat this disease. It can treat sleep apnea. It can so many different things. It becomes like a wonder drug. And I'd like to think that when a drug can solve everything, seems to be too hard to believe to be true. But is it true?
I think that it's important to always have that mindset that there's no silver bullet for anything really in life, and medicine is included there. But on the other side, treating obesity really can improve the state of a lot of comorbid conditions. So when we're seeing the data with cardiovascular disease, sleep apnea, CKD, I'm sure will come out for obesity soon as well, liver disease, it really is the case that these GLPs and the newer medications are the superwoman of treating cardiometabolic health. Instead of treating all these conditions separately with all of these different medications, for many patients who are not deep in disease state, you're able to treat the obesity and then see improvements in blood pressure, cholesterol, fatty liver disease, sleep apnea, and arthritis, all of these things. So I wouldn't say that everyone will be free of disease, but we will see a big reduction in need for other medications to treat these other conditions if we're able to treat obesity appropriately.
Yeah, no, I think that's exciting. I think that if that can benefit a lot of people, we should all, be happy and embrace it.
I think the other really important thing when we think about what it means to treat obesity is around targeting health outcomes. And so when you look at something like the MACE data from the SELECT trial, which showed a 20% reduction in cardiac mortality, those patients had lost around 10% of their weight loss at 5 years. 10% is not a huge amount of weight, but it is a huge impact on health. And so as we're talking about treating obesity, we're not treating someone so that they look a certain way in the mirror afterwards. We can see 10% body weight loss and have massive, massive improvements in your overall health and your overall health span and longevity. And so it's key for people to realize that. It's not like now with Wegovy on board, everyone's going to conform to this aesthetic ideal. No, that's not what we're excited about. We're excited because people aren't going to be dying from heart attacks and strokes at the same rate after having lost 10% of their body weight.
Yeah, and I think a lot of the media story tend not to focus on that because they always show pictures of somebody before and after in a very full-on gown with a full-on makeup going to this amazing gala. And that is the image that's stuck in everybody's mind. And how do you convince everybody? Usually what you see on the social media is only represent small amount of the population.
Yeah.
Maybe help us kind of maybe going back to the memory lane. Before the drugs, the treatment of obesity compared to now, how different it is, how much more powerful tool that you have that can make an impact to the well-being of people who have chronic obesity condition.
The thing here is that we didn't go from nothing to something. So there's been GLPs available for treatment for diabetes since the early 2000s. And in terms of obesity treatment, the first GLP came on market in 2013, and that something around then. And that mid-2010s time, there actually were other medications that came on board as well, something like Qsymia, which is an oral medication. And Qsymia and Wegovy have similar rates of weight loss in year one. And so we've had tools for short-term weight loss, but it's always been that gap in maintenance of that weight loss. So before Wegovy came on board, all of the rest of the tools in our toolkit, after a couple years, patients started having some rate of weight regain. And why does that matter? If you gain significant amounts of weight back, you're not actually going to see improvements in health, those cardiometabolic disease that we're really excited about seeing come down with the GLPs. So what changed for us was not, oh, now there's something available. It's that, oh, now there's something available that's actually reducing my patient's risk of morbidity and mortality. And that, I don't think, is what the average person or even the average non-obesity medicine doctor is seeing. They're still seeing this like, oh, there's drugs to help people lose weight. Well, with Wegovy, yes, weight loss, but more in the long term. And then, the new drugs like tirzepatide, that's a whole nother story. So with those drugs, the rates of weight loss are unlike anything we've ever seen before. So it's closer to something like a surgical procedure for weight loss. And that amount of weight loss is being maintained. So, Wegovy was a nice splash, but these novel GLP-GIP agonists and sort of what's being studied on down the line, those are truly, truly game-changing in terms of the amount of weight loss they can provide to patients.
I think the key is to maintain that weight loss. But that's oftentimes, now you start seeing the news that, well, you take it, but then after 6 months, you kind of gain your weight back. Maybe it's not as much, but still gaining quite a bit too. And how do you manage that with the patient? Because it's long-term. And they either go back to the drugs?
Yeah, that's a really good question as well. We work in the context of an academic center. And so my leading principle in life here is that shared decision-making is really important. So I, as a doctor, need to give my patient all of the data, and then we together can talk, and the patient has to come up with a decision that makes the most sense for them based on understanding the full picture. And so we've known this the whole time, that after discontinuing the medication, the studies showed that people regain 2/3 of their body weight back within 1 year. And probably they'll gain all of it back and more if they never go on another medication. So this is not new. And all of our patients, we explain that to. So we say, this is what you can expect in the short term. It's meant to be a lifelong drug, just like any other chronic disease. If we take away the medication, there probably will be a relapse of that condition. And it's not any different for obesity, which is a chronic disease. And so what does that mean? Not everyone will stay on medications indefinitely because of a myriad of reasons, insurance changes, pregnancy, just wanting to stop. There are reasons that people would come off, but there's some key principles here, which is try not to stop cold turkey because that can cause rebound hunger. Really engage in the lifestyle change work. So really think about what you're eating and moving your body. And at the first signs of weight regain, reconnect. Ideally, you would have never disconnected from the providers when you come off the medications. But if you have, once you start noticing any amount of weight regain, you need to reconnect with your provider so that you can monitor that and decide whether or not you need to go back on that medication or on any other medication that we now have on our menu of options.
Dang, so it's not like cure it all, be done with it. But
not for people with chronic obesity. And I think the harm here is all of the people who probably don't need to be on this medication from an obesity treatment standpoint, but just feel like they have a very hard time maintaining a weight that they want to be. And oftentimes these are women. Women are disproportionately impacted by this ideal of thinness. Economically, women are disadvantaged if they're not thin. And so I hear it probably more socially than anything else. Somebody who looks very healthy, but they just want to lose 5 or 10 pounds. And these medications are getting easier and easier to get for people who are who have white collar jobs, who have higher socioeconomic status. And young women or middle-aged women are using these medications on and off, and it can have long-term impact on your metabolism. I'm sure it's happening with men as well, but I think anecdotally I hear it more from women. But you can see how this idea and this really strong idea of thinness has invaded our culture so significantly that now people are sort of misusing this medication.
Yeah, no, I think it's definitely what you see on the news flash. It looks what everybody thinks it looks good, make you feel like you want to look like that and then you change your perception what is good and what's not good. And if you see painting in the old days, what's good as a women image is so different what's good in current women's image, I think. And I'm hoping that things are slowly changing, more focusing about health. But that's, it's harder to see the healthy on the inside than what you see on the outside. And one last question before we go. Running a weight management clinic at UCSF, when you have, especially now with all the advertisement, everybody wants certain medication and there's a lot of shortages for people who need it and this magic drugs. How do you manage that?
It's tough. We at UCSF really pride ourselves on caring for the entire spectrum of the Bay Area. So we see patients with Medicaid, SF Health Plan, private pay, Medicare, and anything you could imagine we see. And Medicaid and San Francisco Health Plan are very progressive in their caring for individuals with obesity. So there is insurance coverage, but access is such a challenge and it's getting better. But when it was at its worst, it was sort of a rat race of what pharmacy had medications available. And our patients who have more flexibility in their days, who have cars, who can call around pharmacies and can drive far places are oftentimes people with more means. And to see that disparity when these, at the very beginning of our patients who probably needed these more, they were more sick, they had more comorbidities associated with obesity, their insurance has covered the medications, but they didn't have the flexibility or means to drive an hour and a half away. That was really disheartening and very depressing. But with a lot of the supply chain issues decompressing with Wegovy as tirzepatide's come on board, we've had a lot fewer access issues. The access issues are still there for sure. It's just not the way it was at its worst.
Well, that's good to hear. And I think with time, hopefully things are improving, and then there's new pipeline kind of help out with the demand and supply balance. So, well, with that, thank you for your time and sharing your story and giving us an insight about what went through in the weight management clinic at UCSF and what challenges that you face and excitement that you have.
Thanks for having me. It's always fun to chat with you, Christine.
Okay, well, thank you, Diana. Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minotto, and thank you for listening.